So to start here, we'll kind of take HER2 altered non-small cell lung cancer as sort of the quintessential case of what we've hoped for these drugs. And this is just to set the stage before we look at this, before we look at the data for the drug that's used in this kind of cancer. That HER2 is a gene that can be altered in a few different ways in lung cancer. The gene itself can be amplified, so that means there's multiple copies of the gene. The DNA can have a mistake in it, which we call a mutation. So there's a little change there in what the DNA actually says, and that can cause cancer to grow. And then the HER2 protein actually, so this is the gene and this is the protein. The protein can be what's called overexpressed, and that would be sort of sticking out in the cell membrane here, and there's many copies of the protein. And that can be more common than either of these other two, the gene amplification and gene mutation. So we'll focus on mostly on the gene mutation, which is an important subset of non-small cell lung cancer, looking at this next slide. So an agent called trastuzumab deruxtecan, all of these drugs are kind of like a mouthful term here. Trastuzumab, so the first word tells you the antibody, and the second word tells you, I should have actually thought about this. The first word tells you the antibody, and the second word tells you sort of the chemotherapy warhead piece of it. So trastuzumab targets HER2, and this is just telling you the chemotherapy part of it. So it's an anti-HER2 ADC in HER2 mutant non-small cell lung cancer, was tested a few years ago in a clinical trial and was shown to be extremely successful. To sort of orient you here, I think Dr. Shields had shown you some of these kinds of plots, and I'm not sure how many of you are familiar with what these look like. This is called a waterfall plot, and each of these bars represents a patient, and this is showing the extent to which their tumor has shrunk in response to the therapy. And so this is the kind of waterfall plot as oncologists that we want to see. That look at this. Most patients really across the board have experienced tumor shrinkage, which is super exciting. But as you can see here, and I kind of have called out on this graph on the bottom, that this was really only super impressive. And so this is the response rate of 55%, but disease control rate of 92%, meaning that 92% of people had stable disease or response to this drug, which is phenomenal, was much higher than what we saw in HER2 overexpression, which, if, as you recall, was the protein that was sort of sticking out from outside the cell. So these numbers were not as good as what we saw in HER2 mutant lung cancer. So I think that's really interesting and sort of a mini case study that really is indicating that what's most important for this new class of drugs is that every piece of this, the antibody, the linker, and the warhead, and the target really matters. So drilling down on the target is going to be a sort of a common theme moving forward when we look at what else has been in development. So because we found sort of this drug that worked really well for patients with HER2 mutant lung cancer, we thought, okay, let's see if we can try to find something that will work for more general lung cancer in general, and really be an option for more patients who don't have sort of the specific marker. Because as you remember from the gene mutation little graph there, that only occurred in about 4% of patients. So we really want to ultimately try to reach a broader audience. And so this protein called TROP2 was sort of an exciting target because it's overexpressed in a big proportion of non-small cell lung cancer tumors. So almost 2/3 of adenocarcinomas and almost 3/4 of squamous cell carcinomas, which is really exciting. And there had been a precedent for using ADCs targeting TROP2 in other cancers. For example, in metastatic breast cancer, which is what this graph is showing you on the right here, the drug sacituzumab govitecan, which targets TROP2, was compared to physicians' choice of chemotherapy in metastatic breast cancer and performed really well. And it's been like, now it's a really standard treatment for patients with metastatic breast cancer. So we thought, let's try to apply that to lung cancer and see what happens. And there were two very similar agents, sacituzumab govitecan, which I just said on the last slide, and datopotamab deruxtecan, which were compared in very similar trials against this chemotherapy docetaxel, which is our very standard second-line chemotherapy for when patients have had cancer grow after they have their first line of treatment. And unfortunately, the results were not super exciting. They were a little disappointing in terms of what we had hoped we would see. In the trastuzumab govitecan trial, there was no progression-free or overall survival benefit. Progression-free meaning like patients did not have more time until their cancer progressed, depending on the arm that they were on. And in the datopotamab deruxtecan trial, there was a progression-free survival benefit, meaning patients had more time until their cancer progressed, but it was only a little bit of time and no overall survival benefit. There might be some other things to consider when oncologists are picking a regimen for patients, including like the schedule that the chemo is administered on, if specific side effects may be, intolerable or sort of less desirable for some kinds of patients. These ADCs did have a higher response rate than docetaxel, which is, something that may actually come into consideration if people have really symptomatic lesions, like in the chest where it's causing trouble breathing or pain related to lesions. So it's, shrinking can sort of be a good marker there. And then of note, the datopotamab deruxtecan drug did perform better in adenocarcinomas, not so well in squamous. So that might be something that we would also sort of take into account. So, but I think we're not quite ready to give up on these drugs because I think that if we could just sort of, as I'm saying, find the right marker, find the right target, maybe we can sort of understand in whom should we apply these novel therapies. And at World Lung this past year, which is a conference where it's just totally focused on lung cancer, there was a presentation where we saw that, this word immunohistochemistry means basically TROP2 on the surface of the cell did not predict who is going to respond to these drugs or not. And that's kind of counterintuitive because if the antibody is targeting it, you would think that that should be linked, but unfortunately it's not. So we have to think a little bit more creatively about how we can understand why and how these drugs might work. And so scientists then have now tried to understand, is there a different way that we can look at TROP2 and better try to predict which patients' tumors might respond or not? And so they've come up with this sort of novel way to measure TROP2 via computational pathology. So it's sort of automated via computer measurement, and it calculates the expression on the outside versus the inside of the cell. And they found that this novel measurement has been more predictive than standard methods that are being used so far. The issue is that so far this is just sort of like within the context of clinical trials. And so I think, the challenge and the opportunity here is to really disseminate this to, the oncology community at large, and how can regular oncologists sort of get their hands on this. Even academic centers may not have access to this kind of technology yet. So I think that's sort of the next big frontier in terms of trying to apply these therapies.